Welcome to Raaonline. I'm Dr. Venkateswaran, consultant psychiatrist. Today we'll discuss about depression in children and adolescents. So today we are going to discuss about depression as well as about management of suicide. So depression is roughly present in children in two ways. One is major depressive disorder and other is dysthymic disorder. In both these cases, there is significant improvements, which means reduced functioning in one or more areas of life, including academic performance, family relationship and peer interaction. So prevalence of major depressive disorder MDD in children is roughly 2% in children, and if you see like in adolescents it is increasing 4 to 8%. So the risk of depression increases by a factor of 2 to 4 after puberty. So that is why you see it is less in children around 2%, but it increases in adolescent. And male to female ratio is equal in childhood, 1:1, but if you see in adolescent the female incidence is more and there is high female preponderance. Okay, and approximately 5 to 10% of the children and adolescents have subsyndromal depressive symptoms. Here they will not qualify for a diagnosis of major depressive disorder or dysthymic disorder, but they will have lots of subsyndromic symptoms, which is hard enough to reduce their functioning. Okay, so we cannot ignore these subsyndromic depressive symptoms in children and adolescent population. And what is the clinical criteria of depression? Okay, as per DSM-5, the child or adolescent must have at least 2 weeks of persistent change in mood, okay, manifested by one of these major criteria, either depressed mood or irritable mood or loss of interest in pleasurable activities. Okay, this along with one of these symptoms, wishing to be dead or suicidal ideation or attempts, basically suicidal ideas. Increased or decreased appetite. Appetite can be either increased or decreased. At the same time, increased or decreased sleep. Sleep can be either increased or decreased. And loss of energy, decreased activity level. And poor concentration, that is cognitive side effects. And depressed cognitions, decreased self-worth, exaggerated guilt. Okay, they will have hopelessness. Okay, so these are the symptoms of depression that should be there at least for 2 weeks, causing impairment in overall functioning. And it is not exactly as it presents in adults. Okay, the difference can be attributed to child's physical, emotional, cognitive and social developmental stages. Okay, here the child is growing, okay, and they have not have complete physical or emotional maturity and cognitive maturity. So the presentation of symptoms also is highly variable. For example, children may have more mood lability, irritability, low frustration tolerance. It may present as non-specific temper tantrums, sudden onset temper tantrums, or it may present as vague somatic complaints like body pain, headache, abdominal pain, etc. And sometimes it may present just as social withdrawal. These are very non-specific presentation. Here instead of low mood, it is more of an irritability. They won't verbalize feelings like in adult. Okay, in adult they will be able to verbalize their depressive symptoms, but in children they will present with one of these symptoms. Sudden onset, the child was doing well, adolescent was doing well, suddenly 1 or 2 months they present with these symptoms, which is suggestive of depressive episode.